YouTube channel. There are about 2 different teachings on ECG that me and him did together from the previous years. You can go and rewatch it again. And we did a recent webinar too that is also there. And this one, our recording, will also be there for you to rewatch again and again. But for you to understand ECG, don't say that the slides are coming. If you don't write, you will not understand it. No, because, so you must write. So that is why we gave you a book and a pen. We gave you a book and a functioning pen. You must write. If you don't write, then nobody can say that I violated advertising commission. I mean, what is it? That I gave false advertising. Because if you don't write, you will not learn. I don't care who you are. You must read. You read ECG today. Okay, so lights guy, you're going to be my. I want to use somebody that is not a medical person at all. The last time I used Pamela, I want to use somebody that is not medical at all, that can prove to me that we can read ECG. See our dietitian there, she can read ECG. Cynthia, come and take the lectures. All right, so number 1, believe that you can read an ECG. That's the first thing. Number 2, you need to get a pen and a paper and you must write. No shortcuts. If you are not writing, forget it. Number 3, you need to practice, and you will see that there's an ECG workbook in your jotter. There's an ECG workbook in your jotter. We're going to practice it. Maybe I should publish it as a full book. And in your jotter too, you will see an ECG reading algorithm. Is it there? There should be an algorithm for reading ECG. It's in your folder. Check in your folder. There's a big paper that says ECG algorithm. Yeah, yes. Thank you. So that one, you can have it handy and look at it again and again and again and again. Then, number 4, some things must be memorized. You write it down, we'll use it, and you must just keep them in your head. So there's no shortcut to this one. So let me not tell you that everything is easy, you can just read. No. If you cannot memorize some basic things, you will not be able to read an ECG. Okay? And by this time next year, I'm going to try it with my son, my 12-year-old son. I'm going to teach him ECG, and then just to prove that anybody can read ECG, and he will be a part of the advert. Okay? And then keep the understanding of the heart while interpreting the ECG. Very, very important. Okay, everybody seated. You have our basic rules. Hello? You have our basic rules. If you don't keep to these rules, I'm not the one at fault. If you keep to these rules, you will read ECG today. Confidently. So ECG is good because it's recording electrical activity of the heart. It is cheap. It is widely available. Okay, like I said yesterday, you don't need so much money to do it. Almost all hospitals should have it. If your hospital does not have, how many hospitals don't have ECG? You don't have? Kai. Oh my God. What a pity, baby. You must get an ECG. You must get an ECG. Now, there are several reasons why you must get an ECG. Number 1, it saves patients' lives. Number 2, it is cheap. You cannot manage hypertension, diabetes without it. Now, people pay for it. You get money. It's a win for the patient. You get to practice. When you do ECG, you get to practice. You learn better. It's a win for you. The patient pay money. It's a win for the hospital. So it's a win all round. Do you understand? And unlike lab tests or whatever, ECG does not have much consumables. Just paper or gel. That is all. So you will do again and again. So revenue-wise, hospital, win. Patient-wise, good healthcare, win. Your own experience-wise, win. Why don't you have an ECG? So if you want to make a case to your medical director, tell them this one, that this is how much money we can make. Abi? They will answer you in your heart. Don't say, Oga. So, what else again? Also, it's useful for non-electrolyte derangements. So, waiting the lines means self. How many people have always thought that ECG is jaga jaga? Everybody? There was one of my friends that said if they ask me ECG in final part 2, he would just tell them, don't worry, I'll come back. Now he's not going to read it. He's not going to try to learn it. If they ask him, he will keep on coming back. That he's not learning, that's beyond him. But I can tell you that it's not beyond you. So this is what it means. This is now you have to pay attention. It has this P wave, Q wave, Q, R, S, and T. P, Q, R, S, and T. Once you understand this, you understand ECG. It's like I play the piano. Once you understand the 8 notes, you can play the piano. So this is P, Q, R, S, and T. That is the entire end of ECG. Once you understand this, you understand ECG. What you are now looking at again is what does that mean? First of all, okay, so that's P, Q, R, S, and T. Now I'm going to give a very important definition that you need to know. The P wave is the first positive deflection on the ECG. The Q wave is the first negative deflection after the P wave. You need to remember that. I will tell you why it's important later. So there are some things I told you that you must know. These basic definitions is what differentiates people reading ECGs. The Q wave is the first negative deflection. So if there is something small that goes up before the Q wave comes up, it's no longer a Q wave. It must be the first deflection that is negative after a P wave. That is the Q wave.
And maybe I should quickly add, this thick black line is what is called the isoelectric line. Anything above it is a positive deflection. Anything under it is a negative deflection. So that's why he is talking about first positive deflection, first negative deflection. So anything above that line is positive. Anything below it is a negative deflection.
Okay. Are we all clear? Any question? This is not simple. Anybody can tell up and down now. Uh-huh. Now this strip we are looking at now like this, is it predominantly facing up or predominantly facing down? Up. So we say this is positive. Sometimes it's predominantly facing down. We'll say that is negative. You can read ECG now. Come, let me give you certificate, cardiologist. All right. So the next important thing now is knowing what stands for what. The first part of this ECG is when the atrium is depolarizing. So the electrical activity goes around the atrium, it depolarizes or gets charged, let me use charged, and then it contracts. You need to remember this. When ECG gets jaga, this thing I'm telling you is what you're going to use to solve that problem. That's why I'm taking it step by step. The atrium gets charged, that's equals to the P wave. After the atrium gets charged, there is a delay called a PR segment. It's a delay at the AV node in between the atrium and the ventricle. Atrium, Abi, you all know atrium, I will know ventricle, Abi. In between the atrium, so atrium gets blood, pumps it into the ventricle, ventricle gets blood and pumps it to the blood body. Not so? Good. Now, so that the ventricle does not get the electrical activity scattered, the AV node will tell everybody to wait, like customs. Collect everything together and then take it down to the ventricle through one pathway. Okay, now, no? If you don't have this delay, there will be problem. If the delay is too long, there will be problem. If the delay is too short, people will start looking for boycotts. Some people will not wait again. They will jump it, and there will be problem. Okay? So this delay is very important, this PR segment. The next one we are seeing is the QRS. The QRS is when the ventricle is getting charged also to pump. And the last one is when the ventricle is coming back to normalcy. And then the process starts again. Are we all together? No, we're not together.
So P wave is when the atrium is getting charged or contracting. That is what we see in number 1, number 2. Then after that, we have that short delay for all the parts of the atrium to get charged and for all the electrical activity to come to that point before it moves down to the ventricle. That is the PR segment. Then you now have your 4, 5, 6. That is the QRS. That is for the ventricle to get charged and contract. Then the T wave is when the ventricle is now relaxing. That is the old ECG tracing for you.
Any questions? Ask. Just raise your hand. If you don't understand it, I'll go right again. If you don't understand it from here, we're going to have problem going down. Don't worry. Nobody will laugh. Just raise your hand. Yes.
P is for the atrium. The PR segment is for that time waiting in the AV node before the impulses move down to the ventricle. The QRS is ventricle. QRST is the ventricle.
So P wave, it goes round. PR, waiting here. QRS goes round. T wave, it is getting itself back to prepare for another one again. Okay? I think it's clear now. So before we start getting complex, let's just understand this. Okay, so not bother about this too much.
Let's go. We'll talk about this later.
Okay. So another way of looking at the lines is that each line also represents a part of the heart. And they come in groups. This is one of the things you must cram. So write it down. You must remember this grouping. Okay? Just like we have G5 governors. This is how the grouping is. So this is how the grouping is. One person cannot be saying something. All of them must be saying the same thing at the same time. Do you understand? If we find ST segment elevation in only lead 2, we don't find in 3 and F. Something is wrong. That person is lying. So at least 2 people from any of these groups must talk for us to agree that something is going wrong. Do you understand? At the voice of 2 witnesses, a matter is confirmed. That is the ECG here. We need at least 2 people in any of these segments. Once 2 of them come together and agree on a matter, we say that is what it is. So you need to remember this one. Inferior is what? 2, lead 3, and AVF. Lateral is 1, AVL, V5 and V6. 1, AVL, V5 and V6. Anteroseptal is V1 to V4. Okay? These are the basics. We are not yet started reading ECG. Once you understand this one, Shikena, the rest is just toying around with this. God try, Sha. Do we all understand? Do you all understand? This is beautiful. Any question? Anybody not understand anything here? It's just straightforward. Just remember these groupings and then we'll use them later. Okay, so basic ECG template. Like I said, we have summarized it. Before we used to have a 10-step process here. We have reduced it further this time to 6. So identify the name and the calibration. Occasionally, patients are referred or seen with the wrong ECG. Heart attack, wrong patient's ECG. The heart attack person, you allow him to go home. The other person in front of you doesn't have anything. You are terrorizing their life. Always check the name. Cross-check the name. Cross-check the calibration, whether it is too fast or too slow. So cross-check that. So identify the ECG number 1. Number 1, let me just go through it. Number 2, rhythm and P waves. Number 3, QRS. Number 4, ST segment. Number 5, Q wave. Number 6, T wave. Just exactly what we have learned. P, QRS, ST, Q, and T. Where? What did we leave out? We did not talk about PR segments, but no, let's leave it for now.
And other segments.
Okay, another segments. This is simplified. Now, some of you have learned something before, and you are arguing with me in your mind. Keep all those highfalutin stuff. Just learn what I'm saying. At the end of this one, when you understand my own, then now bring back your own. For now, just imagine you don't know. The people that learn ECG the best are the people that have no idea at all. Once you begin to overthink it, problem. Just follow what I'm teaching now. Don't think of anything high. I've removed the one that you don't. These are the one you need for your practice. The other one, axis, all those kind of things, leave it alone. And let us be using it to eat bread. So, number one, identify the ECG. Check the correct name on the ECG. Check the speed and calibration. This is always written at the bottom of every ECG. Check the speed and the calibration. Check the correct name. This is very simple. Check okay? Is there anybody like that? Where did I get that name from? Then number two, check the rate. Okay? For the rate, the rate is simple. What do we do for the rate, Dr. Aliko?
Okay. For the rate, if you look at your ECG, you will see that the ECG, the tracing, you have small, tiny boxes, and you have 5 of that to make a big box. So when you want to calculate the rate, there are 2 formulas you can use, and that's why we said there are some formulas we must have at the back of our mind. And when you want to calculate the 2 formula, the number one is, if you are using the big box, that is the one that has 5 tiny ones inside, is 300 over the number of big boxes between 2 R waves. At least that is why we started from identifying the PQRS complex. So here we are making use of our R waves. So what you want to do is look at the number of big boxes between 2 successive R waves. So it will be 300 over the number of big boxes between 2 successive R waves. That is number one. So if you want to use that, let's use that one alone so that we don't make things complex. So if you want to do that one, if we're starting from this first one, these 2 R waves, if you can see well from your side, it looks as if there is, how many? It's just 1.
1 box. 1.
So if you say 300 over 1, so for this one, it is 300 beats per minute.
So if you have a good patient monitor, it will calculate it for you. But occasionally it may be wrong. Or it may be calculating the pulse rate, which may not match what is happening in the heart. So the heart can be going 150, 300, and people are just using pulse oximeter and writing something. So you should be able to look at it. Once you see 1 box, some people even cram it. 1 box is 300. 2 boxes, 150. 3 boxes, 100. 4, 75. 5, 60.
Using that formula. 300 over the number of big boxes between 2 successive R waves. With that, you have gotten your heart rate.
Is that easy? Any problems? If you have a problem, just raise up your hand. I'll go over it again. Okay, some people have problems. Okay, I need microphone around so that I can understand the problem. But what you do is look at the R wave. Can you see this one R wave? Remember PQR? Can you see the R wave? From the peak of this R wave to the peak of this R wave, how many boxes are there? 1, 2, 3. 300 divided by 3 is equals to 100. That is what it is. Is that clear? You have another question?
Somebody want to ask a question?
Please ask. Now what do we come here for?
Okay, I actually lost it when you were talking about the initial number of boxes. I don't know if you can come over that again.
What is the initial number of boxes?
From the first one, you said 2 successive R waves. Okay,
so what he said is, look at just follow what I'm saying now. This is the R wave, this is the R wave. So that means 2 successive R waves. Count the number of boxes between them.
Between the 2 of them.
And then 300 divided by the number of boxes between them. That's all. Once you see 2 boxes in between them, you are talking about 150. You are likely in trouble. That's when we go to ACLS. So when we go to ACLS, we are going to use all of these things because you are going to read it and know what to do. Okay? You will not be doing MP at that time. Yes, please.
What if the boxes don't fit perfectly? What if we have like outliers? Do we also count them that have like smaller squares, maybe 2 or
What I always advise is, if you look at your ECG very well,
One will land.
you will always see one that falls within those boxes. So it makes it easier for you to just use that. And like we said, if I get 85, you got 83, 84, 87,
It's not much.
it doesn't mean anything.
Okay, sometimes you can have 2.5. It can be 300 divided by 2.5. Okay, so you likely get about the same thing. Okay, let's give an example.
Somebody is also
Okay.
still racing.
Yes, please. Whatever
Thank
enter the
you.
middle,
How about using the rhythm strip? Since it's a 10-second strip, so you count the number of carriers completed.
just stay here for now.
We are
Say-
trying to make it very
Leave
simple.
all those ones. Now, waiting they make people not to remember ECG with that. This methodology is what we have used to cut down all the things that you don't need. This is the one that you will use and eat bread. Some of you will go and start signing ECG now to 2,000 naira a pop. This is the one, straightforward. Okay, fine. So let's look at this one. Can somebody tell us the rates? Can somebody tell us the rates? Yes. Yes. Yes, please. Somebody is there.
According to the ECG, the
The only
heart
one
rate
that
is
according, just say the rates.
150.
150. Are you a politician? 150, Abi? Yes, so we can see 2 boxes there. 1, 2. You can find one. You always find one that lands on the one. So that is like here now. Can we see that? Between 2 of them, 150, about 150. You see this one, your nurses should know this is a red flag. This is not the one you just continue, you say you're handing over and you go. No. This is a red flag. The next thing you will hear is that patient has gone. Okay, people don't just die. Okay? Yes, are there any questions? Easy, Abi? Very easy. Don't worry, I'm coming. We will soon start getting less easy. What about this one? Yes. I'll start picking people. Oh. This man with a very nice face cap. Please bring cap. He wants to say something. Abi, you want to say something? Yes, thank you. Just try.
So 60.
60. How did you arrive at 60?
Let's say from here,
1, 2, 3, 4, 5, 6.
and small.
6 and small. 300 divided by 6?
6.
50.
50.
So
So
you
if
get
you
it
say
about
50,
50, 48.
if some people use this 40 something,
48, 50, that will be more correct. I mean, are we all together?
Yes.
Is it not simple?
Yes.
What are we talking about before now? What about, is it the same one? Has it moved?
it's the same thing.
It's the same thing. Okay, so next, rhythm and the P wave. Rhythm and the P wave. Very simple, rhythm and the P wave. And for this one, we ask ourselves 5 questions. You have to write this formula. You ask yourself 5 questions. Okay? Anybody that's writing? Is there any of the non-medical people that are writing? Vastovas, are you writing, or Codex? I have a gift for you. Are you writing? I'll test whether you understand, just to be sure. All right. So you ask yourself these 5 questions. Number 1, are the RR intervals regular? That is the distance between each of them. Are they the same? Number 2, is the P wave upright in lead 2 and inverted in AVR? Number 3 question, are all the QRS preceded by a P wave? And then does every P wave have a QRS after it? It looks like the same thing, Abi. Like P before QRS or QRS after P. Is it not the same thing? It's not the same thing. Don't worry. When we get to difficulties, you will know the meaning of these questions. And number 5, are all the P waves alike? Do they look alike? Okay? Simple. Hello? Hello? What do we mean by upright P wave? Is this P wave upright or facing downwards? Upright. So, Shikina. Dr. Olalekan, we are doing a good job. We have many cardiologists in the room. Okay. Bagam. Yes?
I think people are still writing.
Oh, okay, I see writing.
So it's when you have all this fulfilled that you can say
Sinus.
the rhythm is a normal sinus rhythm. So
This is what you are checking in your P wave now. Leave other highfalutin things, just focus on this one for now. RR regular, P wave upright in 2 and inverted in AVR, QRS before P wave. QRS, there's a P wave before QRS, and every P wave has a QRS after it, and then do they all look alike? Okay, we have to move. Ain't got all day. So is this sinus? Is this sinus rhythm? Yes. Somebody.
using the criteria.
See her with the very nice Ankara pink. Yes, with glasses. She's about to talk. Yes. Ma, you have not followed my hand like that. Okay. Well, she also has pink. You can give her. She will talk.
So all the P waves are regular. Okay, there's a P
Number
before
one,
every
is
R.
there, what's number one?
Upright P wave.
RR. Are they all similar?
Yes.
So this RR here, between here and here and here and here, is it about equal distance?
Yes.
Yes, good. So number 2 question.
The P waves are upright in lead 2.
Upright in lead 2 and
Inverted.
inverted in
Inverted in
AVR.
AVR.
Are they? Is
Yes.
it? Number 3.
Number 3, all QRS are preceded by a P
A
wave.
P wave.
So you look at this rhythm strip on the ground. Every QRS that you see, is there a P wave before it?
Yes.
Good. Number 4.
Then all P waves have a QRS.
For every
complex
P wave,
after
is there a
it.
QRS after it?
Yes.
Can we all see? And then number 5.
All P waves similar and normal.
Do they all look similar
the
and
same.
normal?
Yes.
What is that?
A normal sinus.
Sign your name. 2K there. All right. Are we all together? What's the question? Give her mic. Raise your hand so he can find you.
Sorry, sir. I want to know what is this AVR?
Okay.
Oh, okay.
We have gone too far. This is lead 1, lead 2, lead 3. Okay? The leads we put on the right leg, left leg. Then these are augmented leads. This is lead 1, lead 2, lead 3. This is lead AVR, AVL, and AVF. And this is V1, V2, V3, V4, V5, V6.
That's just it. You know, we talk about 12 lead ECG. You have 6 precordial leads from V1 to V6. Then you have your augmented limb lead and the limb lead that is gotten from spatial arrangement between those things you put on the patient's hands and leg. So you have 6 limb leads and you have 6 chest leads. That's what gives you the 12 leads ECG. So the AVR we're talking about is one of the augmented limb leads.
So on the ECG, you have 12 leads. All of them are looking in different directions. That's why we said you needed 3 looking in one direction to be able to tell you about something about the heart. So now we're looking at AVR. This P wave now, is it facing downward or upwards? Downwards, correct. That is what we expect. For lead 2, is it facing upward or downward? Upward, that is what we expect. So that's what we mean by, that's the AVR lead. Okay? Any other question? Yes, please.
Always negative.
Yes, typically. Okay. If it's positive, there are 2 things that could happen. Well, the main thing is that you put the leads wrongly. Maybe you put right hand on left hand or right leg on left leg. So anytime you see AVR completely facing up, number 1 is that you put it the wrong way, or number 2, it could be a posterior problem.
Or sometimes maybe a dextrocardia.
Or dextrocardia. Okay. The heart is placed in a different direction. But more often than not, once you see it looking normally like this, very likely that the person put the hands like this, or the heart is moved to one direction or the other. Okay? Are we all together? Is it not simple? The place is getting quiet too. Don't fall my hand though. Now we are going to the next one. Sinus rhythm or not? Yes. I need a taker. I need somebody. Quick. We're wasting time. Quick. Yes, okay. Fine. Her friend. She pointed to her friend. Call a friend.
The RR intervals are not the same.
Really? These RR intervals, are they not the same? Okay, yeah, you're right. So. I'm too close to the screen here. Okay. What else?
But
Continue.
the P wave is upward in L2 and downward inverted in AVR.
Where is the P wave? Where did
I'm
you
sure
see?
you can see the P wave.
Is there
very
any
well.
P wave here?
So,
Though?
there is no P wave on L2.
Aha.
Neither can I see on AVR too.
So you cannot see any P wave here. There's no P wave here.
Yes.
Okay. Say again.
Occasionally.
Look at lead 2 again. Look through any P wave. What we are seeing here, there's a P wave actually here. A small P wave that is merged with it, but it's not a normal P wave. This is T. This is QRST, 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 QRST. No P wave.
So one of the criteria is gone now.
So automatically, this is not
Criteria.
sinus rhythm. 2.
So
That means
They are
QRS are there and there are no P waves. Okay? And then we cannot see any P waves. And it's irregular. And even when the one that we saw that looks like query a P wave is deformed. So this is not a sinus rhythm. What rhythm is this? It's on your sheet. What rhythm is this? It's called an atrial fibrillation. Whenever you have an irregular RR interval, you need to write this one. You need to keep it down. Keep it. Because you don't pick this one, the patient is coming to a stroke. You don't pick this one, that patient will never come out of heart failure. Like somebody asking about someone not having heart failure. This may be there. So you don't pick this one, you don't treat it, the patient is not coming out of heart failure. So that is what we are seeing there.
There's no P wave, and the RR interval is not regular. So
Good.
that's atrial fibrillation.
We have to move fast now. Yes? Sinus rhythm or not? Sinus rhythm or not? The man with glasses there, just to your side. Yes. He looks very serious. Yes, in front of you. No, in front of you. Yes, he looks very serious. Go ahead.
It's not sinus rhythm.
Really? Why?
Although the RR intervals are normal, the
Yes.
P waves, there's the QT interval isn't.
Simple. Number 1. What question 1?
The RR intervals
Are they
frequent.
equal?
Yes.
Good. Number 2.
P waves.
P waves. Are they upright in lead 2?
Yes.
Are they upside down in lead AVR?
They're also upright in AVR.
No, they are upside down. See it now.
Okay, they are upside down in AVR.
Correct. So number 2, number 3.
P before.
Are they before the QRS complex?
Is there every QRS has a P before it? Is that correct?
Yes.
Yes.
After every P wave, is there a QRS?
Yes.
Yes.
Do all the P waves look alike?
Yes.
Eh?
No.
Yes.
Which one?
They look alike.
They all look alike. They are all the same. Sinus rhythm.
Don't look at whether the shape of the QRS is abnormal. What we're talking about now is
I know you are looking at this one. I'm
sinus,
looking at this one.
a sinus rhythm. That the rhythm is coming from the SA node. That is all we are looking out for now. So it's a sinus rhythm. The fact that it's a sinus rhythm does not mean that the ECG will be normal at the end of the day. Don't let's get it.
Are we okay
twisted.
with this? Anybody have a problem with this? I should go over again. Eh? I should go over it again. Go through your questions. Question number 1. RR interval, are they equal? They are equal. Forget anything you know again. Just follow this basic rule. Number 2 question. Dr. Lodibia, Dr. Olalekon, maybe, and Dr. Aofiswe, maybe you should stand there, but in case there are some questions that you would have too afraid to ask, you can just answer them quietly. Okay, so number 2 question is
P wave upright in lead 2.
upright.
Inverted
here.
in
Is it
AVR.
inverted here? Can you see the P wave? Is it inverted? Good. Number 3.
QRS preceded by P wave.
Every QRS, is there a P wave before it? Every P wave, is there a QRS after it? Do all the P waves look alike?
The morphology, the shape.
Okay, now. Normal sinus rhythm. Is that clear now? Is that clear now? Just follow it like this, jelly. Don't remember, forget anything you've learned before. This one is what you will use now. Okay? Anybody not understand again? Let's get it hot in here. Yes.
Okay, my question is, I noticed that when you were checking the QRS complexes, whether they are preceded by a P wave, you were checking the lower.
Yes, so
line.
this is what we call it. This place is.
So is that what we are supposed to check and not consider the other?
So
leads?
this is what we call a rhythm strip. You can see it's long and together. While these other ones, they are cut short. You just have a short segment, a short segment. So you use your rhythm strip to see the entire period so that you can be sure about the rhythm or
It's
not.
easier for you to follow a longer reading than just
number
a short.
two thing, use lead 2 you use to check P waves. Please write that down. I think I forgot to say that. Lead 2 and lead V1 and V2. Those are the ones you use to check your P wave. You want to check whether your P wave is good or not. Whatever it is, look at lead 2 and lead. The other ones, P wave might be hidden somewhere. Look at this V2. Can you see P wave there? V2, can you see P wave there? Not really. So you cannot make, but if you look at lead 2, you can see it. So that is where you focus on when you want to check the reading. And you see your reading strip typically is lead 2 automatically from your machine.
It's usually under like this, and you can use that to.
Now some of us have those small ECG machines that print small strip. Even after it prints it, there will be one that will be long that you will use to check the reading. Thank you very much for that question. We'll update it in our updates and make it better. All right, let's get it hot. How did they say? How that song? Let's get it started in here. All right, who's going to answer this for me? Where is my... Pick the person in front of you. Pick the person in front of you. Pick anybody you like or you don't like. Yes, sir. Sinus reading or not?
It's not.
Why?
Why?
The RR is not, the interval is not.
It's not equal, correct?
It's not equal.
What are the P wave in lead 2? This place is...
There is P wave in lead 2.
There's P wave in lead 2?
Yes.
Is it upright in lead 2?
It's upright.
In AVR, is it upside down?
Yes.
Okay. Now, are all the P waves, is there a QRS after them? After all the P waves?
Not all.
Huh?
Not all.
Which P wave doesn't have QRS? All P waves have QRS. See one P wave here? It has QRS. All the P wave QRS, P wave QRS, P wave QRS, P wave QRS. Can we see that?
Yes.
Okay. Now the next question, which is the question that I will now give you the answer. Do all the P waves look alike?
No, they don't.
This one is different. This is the original. This one
Looks different.
is away match. Okay? Can we see that?
Yes.
This one is different. This one is correct from the proper place. Can you see that? So, what we have is an ectopic atrial rhythm. Another SA node, some people call it warning SA node, another place in the heart
It's also generating.
It's also generating its own impulse. So after the normal one does, another place does. That is why it's not a sinus rhythm. Do you understand that? Hello?
So just know that this is not
sinus.
a normal sinus reading.
Once you answer your questions, it's not sinus, it's not sinus. Is that simple? Thank you. Anybody that is still burning them, that's the thing getting hard though. Okay, fine. I want us to know this. If it's not regular, it could be either fast or slow, and there are no P waves. We call that atrial fibrillation. You need to write this one down. Remember I told you, you've written atrial fibrillation before, Abi? You need to write it down. Anytime you have irregular RR interval, please, Dr. Ilodivia is there, Dr. Alfiso is there. In case you have a question that you are too shy, just call them and they will explain it to you quietly in your seat. Where are my other doctors now? Where is Dr. Abdulkadir, Dr. Anya, Dr. Ajibola? Where are they? All right. Okay, so now, if you have multiple P waves, that is, you have P wave, no QRS, P wave, no QRS, P wave, no QRS before you have QRS. We call that atrial flutter. Can you continue?
So what we're saying is, if you look at your P wave, and you can't find a P wave, and the interval between the R waves are not regular, that patient has atrial fibrillation like the ECG we saw earlier. Then you can have ECG where, like we said, that P wave must be before QRS, but you can have occasion where what you have is multiple P waves before you see a QRS, and the RR intervals are regular. That is what we call atrial flutter. I think we will limit that for now. Before we'll come back and talk about the others as we proceed. Let's see what is on the next. So let's look at this.
What rhythm is this? Is this
so what
normal?
do we have here?
Is this normal? Come to this side. Come to this side. You have used those people too much before they hate you. Come. Yes, give her. Thank you. Go ahead.
It's still using the same basic.
It's your turn to shine, 2022.
Still basic.
The camera is focusing on you. You are international now. It's on YouTube. It's on Zoom. All right, give her a friend next to her. Let her call a friend. Good. Thank you very much.
So still using the same criteria.
Okay, the RR intervals are regular.
Okay, thank you.
And the P wave is negative in lead 2.
Okay, in AVR.
Positive.
Is that correct? Is that normal?
That is not normal.
What do we expect normally? Positive in lead 2 and negative in AVR. That already tells you not sinus. Abi?
So okay. Number 3.
Are all complexes preceded by a P wave?
All the QRS, is there a P wave before
it?
Yes.
Good. Then the next question.
Is there a P wave?
Is there a QRS after every P wave?
Every P wave? Is that true?
Huh?
If you are not sure, look at V1. In V1, you will see your P wave very well. So all those are P waves. So what you have is you have multiple P waves before QRS complex. And like I said, on the table we showed earlier, I said if you have multiple P waves with regular RR interval, that is what is called atrial flutter. And if you look at it, the V1, it looks like the mouth of a saw. And that is why they call it a sawtooth appearance.
So you can look here, you can see one P wave here, one P wave here, one P wave here, and one P wave here, before it now had a QRS. Can we see that? Sometimes people miss that, even us cardiologists, sometimes you can miss, you are treating somebody for heart failure, it can be so subtle. If you miss it, that person will not. So when somebody is not getting better, you need to go back again, like a medical student, and just be going through these simple questions. You'll be going through them one by one and find what you missed. And that will just change the day for you. Okay, so this is atrial flutter. All right. Sign it there. Good afternoon, sir. I'm so sorry. I made a diagnosis. Sorry. All right, I'm joking. Yes, who can help with this one?
So, the basic principle first.
Okay, he likes you. Please. Go ahead. It's your turn to shine. Don't worry, I know it's hard. We will not hold you for it. Do you know the funny thing? These things are happening in your practices. I want you to try it out because it's happening there. You may not have put ECG monitor on your patients, or you are doing surgery. You started doing surgery, it is there on the monitor. You don't take notes. Next thing you say, sorry, something happened. You don't even know what happened. The remote control. There's no remote control. This is the remote control. Can we see that here? Can somebody try, please? Can somebody try? Give somebody to try. Just try. Quickly. We don't have time. Everybody's dodging the microphone. Thank you. You need to contest. Go ahead.
Okay.
P wave in lead 2. RR interval, they equal?
The RR interval. They look
What is the rate here? A little bit, yes. A little bit more than
very
150.
high, yeah, very high.
Yes.
There's no obvious P wave.
There is no obvious P wave.
Only 2.
There are P waves there, but
see this small P wave. Can you see this small P wave?
Yes, okay.
Can we see that? Yes, there's a small P wave before QRS.
P wave, QRS, T, P, QRS, T.
Can
It's
you see
because
that?
of the rate.
It's because the rate is very fast. Look at it now. So ECG they be. So I don't leave here tomorrow and say they taught me that they brought the real one. I could not read it again. We are going to read ECG here tired. So don't get. This is the only way you learn it. And if you finish from here, you go to your center, gather ECGs, and read again. Take another 50. Anyone you have problem, post it on the WhatsApp group. Give your interpretation and we'll help you correct. For the next 1 week, just be posting ECGs that you have tried. We will help you correct it. After that, that's all. Okay, the last thing. Catch any group of people that you have control over, even your children, and start teaching them. Once you teach a set of people, you will never forget it. That's how I learned ECG. Okay? So, go ahead now. Okay. P wave is there, is regular. P wave is there before every QRS. What again?
In AVR, the P wave is inverted. So that is in AVR, lead AVR.
Okay.
Okay.
Difficult to see. Continue.
Yeah. Then there is P wave before every QR complex.
Okay.
So this is a sinus rhythm.
From your first principle,
yeah.
As in, before we say something is a sinus rhythm, you should also, don't forget, maybe we didn't have that one, you should also look at the rate too.
Okay,
because your rate already is above
150.
the normal average. So, because of the heart rate, it's a sinus rhythm, but it's not a normal sinus rhythm. Overlooking other things, you can say sinus tachycardia, but that is not what this patient has. But we don't want to. This patient has a ventricular tachycardia, but don't let's make it complex. Yes, but if we look at our basic principle plus the rate, you can say this patient has a sinus tachycardia, but this is an ECG of a patient with ventricular tachycardia.
Let me make it a little bit simpler. Anytime you have an ECG at 150 and above, anytime you have an ECG 150 and above, check the QRS duration. If the QRS is wide like this, that is more this QRS. Can you see the QRS duration? It starts from one box and it crosses one big box. QRS is supposed to be less than half a box, half a big box. Write that down. QRS must be less than half a big box. So once you have a very fast heart rate, you should ask yourself, is this narrow complex or wide complex? In this case, this is a wide complex regular tachycardia. Are we okay? It fulfills the criteria for sinus rhythm, yes, but it is a wide complex regular tachycardia. And there are different things you do. This is an emergency.
Let's go back to our table. So back to our table. You know we stopped here. Now, we're jumping to the number 4 there, which we call the ventricular tachycardia. The one we looked at last, the RR interval was regular. The rate was fast because it was greater than 100. P waves, because of the fast nature, that was why it was difficult for you to see the P wave. But the P waves were there. So, depending on how fast the rhythm is, most of the time you will not see the P wave because it will be buried inside something. Then, the QRS appearance, you said it is wide and it looked bizarre. So, what do you have is a ventricular tachycardia, and we said it is a medical emergency. And that is why everybody must be able to identify this morphology.
This thing must be in your mind. I think, is it there on your ECG sheet? Is there something like this on your ECG sheet? Ventricular tachycardia, is it there?
I think it's maybe inside the book.
Yes, ventricular tachycardia is there. You need to keep it. You need to keep it. It's going to show up on your monitor. It's going to show up while you are doing surgery, while you are delivering babies. It's going to show up. And if you don't attend to it, that person, you're going to lose that patient. It will show up. It has been there. Sometimes you can enter a hospital ward and it is there and people are just sitting down. Then when the patient now stops and everybody starts running. No, you must notice this. So that thing, you must keep it. Paste it around your hospital if necessary. You must keep it. It's not something that you need to look at it again and again and again. Okay? All right. Let's get it harder. Let me jump this one. I think we didn't do this one that time too. Step 4, QRS. QRS duration. So we come to the QRS. And for the QRS, we remember that QRS is for what? What does QRS represent? Ventricular depolarization, when it charges the ventricle and the ventricle contracts. So the QRS should be less than 3 small boxes. That is less than half a big box. That is narrow. And every time it is broad, greater than 3 small boxes, greater than half a box, like I wrote down, that means is broad. If it is fast, we say that is a wide complex tachycardia. You need to know this one. Oh. It's going to be very important in your ACLS. I know we are getting more complex and everything, but, you know, this is how the ECG is. No shortcuts. Just be writing. When we start applying it, you will see how it is. Okay? Typically, anytime you have it too short, we say they have small complexes. And when you have it very big, that's when you have ventricular hypertrophy. So if you have more than 5 big boxes in any of the limb leads, or any of the chest leads, where the right limb lead? Any of the chest lead.
If it is in the limb leads, that is 1, 2, 3, AVR, AVF, AV. If the height of the QRS, if it is less than 5 millimeter, that is, if the height is less than 1 big box, then the amplitude is small. That means the height is low. So you can call that low amplitude. And when you look at the V1 to V6, if it is less than 2 boxes, the big one, then you can say the patient has a low amplitude. That is what we mean by height. Height and amplitude are the same. So if you look at 1 AVF, 1 to AVF, if the height is less than 1 box, the amplitude is low. If you go to V1 to V6, if it is less than 2 boxes, then the amplitude is low. So for this one now, from V1 to V6, the height of the R wave is fine.
Can we see that? See the height of the amplitude here. 1 box, 2 box,
2,
3, that's fine. If it were less than 2 boxes, we'll say the amplitude is low. Maybe there's pericardial effusion, maybe there's a problem.
Or the patient is obese.
Or the patient is very fat. So that is what you look at.
Then
in the limb leads, if
one.
it is less than 1 box, we say the amplitude is low. Low voltage complexes are important because it shows that the heart muscle may not have enough electrical activity, like NEPA. Okay? Very low. Okay? Now, what else do we say about QRS? We say the duration. What about this QRS? Is this normal? Hello?
In terms of duration. Is this normal? Let's look at the QRS
What do we say the normal duration is? Less than half of a big box, Abi. So this one, is it less than half of a big box? It starts from here. Let's look at this one. It started from here, and it ended here. Is that what? That's a big box now.
Yes.
Is that less than half? That is much more than half. That's 1 full big box. Look at this one here too. It started from here, and it ended here. That is 1 full big box, Abi. In fact, it ended somewhere here.
So
somewhere
this
here.
is a broad, complex QRS. So if you
Any
have
questions?
tachycardia
Is it
with this,
ask. If it's not clear to you, just raise your hand. I'll go over it again. It's not clear? Okay, fine. So look at the QRS duration. The QRS is when the thing goes up and down. From the point it starts going up and down, let me look for one that is on the line. This one. From the point it starts going up and down to the point it comes back to the line is from here to here.
That's the old QRS
That
complex.
is one big box. A normal QRS complex should have stopped halfway.
Halfway. Normal should not be more than half of that big box. So once it is more than that.
Look at a normal one here. Is this normal?
No, let's go back a bit. This one.
Okay. Is there the one that starts from a line? Okay, here. Can you see this one here? It starts here and it stops here. Can you see that?
So this is a normal
Can you see that?
QRS complex.
You can't see it. Sorry, you can't see it. There's a TV screen near somewhere there, halfway in the line. You can look at, maybe that's clearer. Let me show you again.
Dr. Ludibia can also.
Dr. Ludibia, if you're nearby, maybe you can just open the book. The people at the back there. You can just open the book and show them. See, it starts from this line and see where it ends. Just halfway. And from the big box, from here to here. And this QRS stopped less than half. That is a normal QRS. Are we all together? Beautiful. It's simple. Don't worry, we are coming. We are coming. So let's look at this ECG again. What is the rate of this ECG? Rate. We talked about it already now. 75. Okay. What's the reading? Huh? Sinus reading. Then, what else did we say again?
So
QRS.
Normal QRS complex.
The QRS complex normal. Is there any QRS complex that is more than 5 boxes? No. Okay. Now we're going to go a little bit deeper in this QRS business. The next one we're going to do in the QRS is to find out if there is hypertrophy. If there is hypertrophy, right ventricular or left ventricular hypertrophy, you need to write this. We're going to use it. Let's go back to that same ECG. Go back. Just stay there. No, before this one. Yes. So on this one, to find out whether it is normal, once this V1 is facing upwards, what direction is it facing now? Down. If V1 is facing upwards, we say that is right ventricular hypertrophy. Please write that down. V1 facing upwards, right ventricular hypertrophy. Is that not simple? You can tell what is up and what is down now. It's just for you to remember. Who doesn't understand? You don't understand? I don't understand. Save me. Okay, fine. V1 facing down, normal. V1 facing up, right ventricular hypertrophy. Now, hypertension most times has left ventricular hypertrophy. If you check, so close to this thing. Let's have one that has V2 facing the other way. Good. If you check this number, how many boxes is this? How many big boxes is that? Is this S wave? How many big boxes is that? Maybe 2, almost 2. You come to V5 and V6 and look at the R wave. How many boxes is that? 1, 2, Abi?
3.
Okay, I'm too close to this thing. 3. 3 plus 2 is what? 5. When it is 7 or more, we say there is left ventricular hypertrophy. When you add this S wave in V1 or V2, the number of big boxes to the S wave, to the R wave
in V5 or
V5 or V6, if it is more than 7 big boxes, we say there is left ventricular hypertrophy. I don't understand. You don't understand? What don't you understand? Which part? In V1 or V2, the part that is facing down, measure what number of big boxes is facing down. Get the longest one. That's the S wave. In V5 or V6, the R wave, that's the part that is facing up. Get the one that is the tallest and measure the number of big boxes. When you add number of big boxes here, plus number of big boxes here facing down, if it is more than 7, 7 or more, we say there is left ventricular hypertrophy. I think that's simple. Yes? I still don't understand. Focus on me. Write later. Just understand this now. I don't understand. You don't understand. Which part don't you understand?
Oh, the left ventricular hypertrophy.
Okay, so left ventricular hypertrophy. Right ventricular hypertrophy is simple. If V1 is facing up, it's right, Abi. In left ventricular hypertrophy, check this V1 or V2. Look for the longest S wave. When you find the longest S wave, count how many big boxes there are. Come to V5 or V6. Look for the tallest R wave. R wave is the one facing up. Count how many big boxes there are. Add the number of big boxes from here to here. Okay? How many votes you have in the north and the south? If the votes are more than 35, you win. Left ventricular hypertrophy. If they're not up to 35, you lose. Normal usage. 7, sorry. 7.
He's
sorry.
saying 35 because inside one box, there are 5 votes inside. So 5 times 7 is 35. But let's just do 7 big boxes. Big boxes.
Is that clear now? Good, beautiful. We can move. One more person. Again. Yes, Solubala. Huh? V1. For right ventricular hypertrophy, just look at V1. Just look at V1. If the V1 is facing up, right ventricular hypertrophy. Ready? Once the V1 is facing up, so you bring somebody that is breathless, rush to your hospital, and you did an ECG, and you saw the V1 facing up, right ventricular hypertrophy. Maybe there is pulmonary hypertension, pulmonary embolism, something like that. You can make, before you start doing D-dimer, all the rest, that already should tell you what is happening there. Now, the blood pressure is high, you're not sure, you want to check whether you want to give AC inhibitors. Now go to it and count how many big boxes. Look at the one facing down in V1 or V2. Get the longest one. 1, 2.5. Come here. 1, 2, 3. The one facing up in V5. Look at the longest one. 1, 2, 3. Add them up. 5.5 is not up to 7. Means it's normal. It's likely to be normal. If it is 7 and above, the heart muscle is ticking. Left ventricular hypertrophy. Okay, we are moving forward. The rest of you, in the dream, it will be revealed to you. Okay, but don't worry. As we continue answering more questions, you're going to understand it. Yes, please.
Sorry, sir, please. I'm taking us back to the QRS complex. Just clarification. Did you say the QRS complexes in the precordial limbs are taller?
Yes.
Yes.
Okay.
Precordial limbs are close to the heart, so they'll be taller.
Okay, so 2 big boxes.
Yes.
Then for the limb leads,
one
big box. Thank you, sir.
Those ones are further away from the heart. So the next thing we want you to go back, please. The next thing we'll look at this QRS again is a bundle branch block. Why is a bundle branch block important? A bundle branch block is important because a left bundle branch block may be the only thing you find in somebody that has an MI. We talked yesterday about ST elevation, Abi. Who remembers? Talk about ST elevation. Some people don't have ST elevation. All they will come with is a left bundle branch block. If you are doing USMLE, you'll be familiar with this acronym. And I don't think you can even practice as a nurse outside this country without understanding ECG. In this country, I think it should be a law too. You should not be able to practice without learning ECG. Anybody. Okay? So, once we have this deep RS wave, what we call W, in V1, and an M-like wave in V6, we say that is a left bundle branch block. That's why we have this acronym, William. W in V1 and M in V6. When we have it the other way, an M in V1 and W or a big V in V6, we call that a right bundle branch block. Again, the QRS complex will look jaga-jaga like this. It will not look like the normal QRS complex. That jaga-jaga in V1 and V6, we use that to define whether that is left or right bundle branch block. In the right bundle branch block, in V1, it will be M shape. Can you see M shape? In right bundle branch block. That's it there. That's in V1. While in V6, it will be W shape. Sometimes it's not full W, it's just one U. It's not a double U. Okay? We call that left bundle branch, a right bundle branch block and left bundle branch block. If somebody comes with chest pain, and this is the ECG you see, that person is having a myocardial infarction until proven otherwise. You need to get a troponin immediately. Don't send the patient home. Don't give them a referral and say, see cardiologist in 2 weeks' time. No. You need to keep that patient and do all the necessary things. You will lose that patient. Okay? So can you go to the next slide, sir? Real life. Don't worry, you'll get it now with real life. Real life. Look at this ECG. Is the QRS duration normal? Yes? Who said no? Yes.
No.
Why do you say no?
Yeah, is the QRS complex is up to one big box.
It's up to one big box, so it's prolonged.
Yes.
Meaning there's a problem in the conduction. Now in V1, is that QRS looking normal? V1, V2, is it looking normal? In V1.
In V1.
This is V1.
Yeah, it's normal. It's half. Huh?
V1, this is V1 now.
Okay, V1. Sorry. No, it's up to one big box.
It's up to one big box. Does it look normal? Forget the duration now.
No, it's not normal.
What does it look like?
Yes, there is an M there.
Correct.
Okay.
RSR, we call it. Perfect.
Yeah.
You know the technical term. But we just call it M. M like this. Abi?
Yes.
Correct. M in V1. Where do we go again? We look to V6. Do we have anything that looks like a U or a W here?
Yes.
So what kind of bundle branch block is this? Right bundle branch block. Check your paper. Check your paper. What did you write?
Marrow.
Right, marrow. M in V1, W in V6. If this switched, it would have been left bundle branch block. Apo, for those that speak Idoma. Inanokwa, Igbo, Kunaji, Yatigbo. Sorry, I don't remember Fulani and Igbira. Okay, fine. Any questions so far? Questions? Let's go on. As we go, we will continue to move on. I think we have done that one. And then, step 5, ST segments. ST segment. We are finished. Now we are going to just do practical. We are finished. And you will see how easy it is. Okay?
So, ST segments, we're looking at that line between the T wave and the end of the QRS complex. And what we're looking for is whether that line or whether that line is still on that horizontal line or is either above or below. So if it is above what you are looking at, that is when we say there is ST segment elevation. If it is low, below that isoelectric line, we talk about ST segment depression. And this is important because, like we talked about chest pain yesterday, chest pain in the presence of abnormality of that ST segment is very, very important. That is what is going to help you to know whether your patient is having pericarditis or whether your patient is having heart attack. So like we said, that line is what we are interested in. Let's go ahead, the next slide. And so, we've seen the line, and you may want to trace that line to join your P wave so that you will know, because that ST line will not be there. You will still need another reference. So you can extend that ST line to the next P wave to be able to identify what the isoelectric line is. Then you now move to B. In B, the line is supposed to be here, but it is here now. So that is ST segment depression. We can see that. The J point we are pointing to, that is the end of the KRS complex and the beginning of that line. So you can see that that point is down. And the whole of the ST line is down, and also dragging part of the T wave along with it. Then C, you can see now that it is now above that isoelectric line. So C is ST segment elevation, while B is ST segment depression. That is all you need to know about that.
Hello? Are we together? Not yet. I've started losing some people. Just take a deep breath. In and out. This is the meat. We are getting to the meat of it. ST segment elevation and ST segment depression. If you have chest pain and you have ST segment elevation or depression, what you are dealing with is an ischemic heart disease. Hello?
You have blanked us out.
All right. All right.
This one here. This one ST segment elevation.
Let's leave down when we are doing Is there any question about the elevation and depression?
Okay, we can. This one.
Any question about elevation and depression? While they are fixing that, can we look at page 45? Page 45. Okay, go ahead, sir.
All right. Thank you very much. So I just wanted you to clarify where you would have like something that sometimes cardiologists talk about having normal variants in V1, V2, or benign early repolarization. How you wouldn't consider that as actually a significant ST change?
We're just trying to wait for the screen to come out so that we'll be able to see the pattern.
I think you can manage to see the benign here.
Okay, the benign is there. So, when we talked about, first of all, we want us to be able to identify the depression and the elevation. Then, when you now talk about the elevation, we're talking about looking at the J points and also looking at the shape of that elevation. In the benign early repolarization changes, the J point is still on that isoelectric line, while the remaining part of the ST segment might be elevated. So that is like a normal variant you can see in young adults, and it is not pathological. But in others, you look out for the J point. The J point moves either up or down. So that one, you know, this one, there's issue here, there's a pathology that you need to identify. So you can have benign early repolarization changes where you have in young adults, especially maybe tall, thin individual, you can see those ST segment changes. And another thing that will give it away is if it is related to heart attack, like we look at the ECG looking at different area, you see those changes in a specific area. But for the benign repolarization changes, it's going to be generalized. It's not going to be restricted to a certain part. So what do you have here? So like you said, the J point is still around the isoelectric line, and you have the whole other area elevated. But for the other one, look at the J point for this. Look at that, and that's what you have in.
I think I will just leave it benign early repolarization. Let's not confuse everybody.
So we just don't want to go to all those details so that we don't get things complicated.
Do we understand depression and elevation? ST segment is depressed in B, is elevated in C. Do we understand that? Beautiful. Now, this is now where you bring back this thing. That depression or elevation, it must happen in at least 2 contiguous leads. You remember we wrote this one before? Check your notes where you wrote this one. it must happen in at least 2. If you find only 1, you are not talking. You are not yet talking. If you find only 1 bit, that is all the bits were there, just 1 bit went up a bit, leave that one alone. It must be in almost all the bits, and it must be in at least 2 leads. It cannot be in lead 1 and lead 2. Why? They are not related. They are not part of the G5. Okay? Only lead 1, only 2 people among the G5 can talk together. 2, 3 AVF are together. V1, V2 are together. V3, V4 are together. 1 AVL, V5, V6 are together. Do you understand? They must be together. 2 of them must agree concerning this elevation or depression. Are we together? Let's look at this ECG. Number 1, what's the rate? Rate? Yes, ma. What's the rate? 75. Okay. What's the next thing again?
Is it sinus rhythm?
Is it sinus rhythm? Give her.
Yes, it is.
Yes, it's a sinus rhythm.
Okay, fine.
Yes,
QRS.
P wave. There's a P wave before.
QRS.
It's
The QRS, is it normal?
It's normal.
Is it wide?
No, it's normal.
Okay. So
QRS is normal. ST segments.
ST segment, any abnormality in the ST segments?
Yes.
Where?
It's elevated.
Where?
Where?
I'm looking at V3.
Eh?
AVF.
AVF. If you see in AVF, where else
should
will
you check?
Check your book. Check your book. You wrote it down.
That is why you have-
2 and 3.
So
Lead 2 and
look at
3.
those areas.
Lead 2 now. Is it elevated?
Yes.
Lead 3
Lead
come?
3?
Yes, it's elevated.
At the voice of 3 witnesses.
A
So
testimony is
in
established.
which area is this now?
The 2-3 AVF.
What do we call it?
Inferior.
Yes.
Inferior. So this is an inferior ST elevation.
MI.
MI. Or you sign your name, cardiologist. You made the diagnosis.
So this patient has inferior ST elevated myocardial
I remember this
infarction.
man. He was very fit, slim guy. 2016. Slim guy. Nothing, no hypertension, no diabetes. This was all that was there. Some chest pain, and he rushed into the hospital. Okay? Inferior ST segment elevation MI. Can we all see this one? Very easy to make a diagnosis. Okay. The next part of it now, the other segments. We'll look at the PR segment, which is depressing pericarditis, but you hardly ever use the PR segment. So this PR segment, can you see the PR segment? Sometimes it goes down. You have the S elevation, and then you have PR segment going down. That could happen next. The one I want you to see now is the Q wave. Should we bother about Q wave? I think we should. It's called Q wave MI. Who remembers the definition we said about Q wave? First
Deflection.
negative deflection after a P wave. First negative deflection after a P wave. Remember this. Okay? So, the depth of the Q wave must be at least 25% of the R wave, English. P, Q, R. That Q wave that came down must be at least 1/4 of the height of the other one. A. Hello? Ah, people are getting quiet. The hall is getting quiet. Should they bring lunch? This Q wave is like S elevation. It must also happen in contiguous leads. Hello? If you have somebody coming with chest pain and has Q wave, that is a significant Q wave that is deep or wide in contiguous leads. That person is also likely having an end-stem MI, a non-ST segment elevation MI, or has had an MI before, or they are still having a MI currently ongoing. Let's look at this. I remember this person. It's an Indian lady. An Indian lady. Yes, that was 2016. Yes, 2017. Anybody? Any takers? Good, pick somebody, they are not coming. Good. How can you wear suit like that? Answer, you are wearing suits. Remember, I give you mic when you can't teach. Just go ahead. Answer.
So what is the heart rate?
Still accessing, sir.
Just try. What is the heart rate? Anytime you see ECG, don't be afraid. Just follow what we have taught you.
What is the heart rate?
100.
100, good.
Beautiful.
What is the rhythm? All of you should be trying. Say it out near your table.
Sinus rhythm.
Sinus rhythm, good. QRS.
Wide.
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 Okay,
yes.
no, it's
Slightly
normal.
wide, normal. It's about
It's
half.
normal.
It's about
It's
half.
It's
normal.
about half. Okay.
Yeah, it's normal.
Fine. ST segment.
ST segment.
Elevated.
Where? That's
Three.
the next question.
Huh?
Elevated in limb 3.
3.
Okay,
Very
no.
small.
Very small. We have other obvious ones in other places. Look at the whole ECG.
Look at the whole ECG. This is why you must have a 12 lead
Whole
ECG.
ECG.
You cannot use all that one on the monitor and we say there's no
V2.
ST segment elevation. You must do a 12 lead ECG to see
Look at in
everything.
V2.
Lead what?
V2.
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 If you're elevated in V2, which other one is the brother of V2? Open
Two.
your book. Open your book. Everybody, open your book.
V1.
V1.
Okay, so check V1.
It's just elevated there.
Yes.
Correct. Where else is it elevated?
Where else?
V3.
Where
Where's
is-
the brother of V3?
V4.
Is it in V4 too?
Slightly.
Yes.
Okay.
Slightly.
Beautiful. So what kind of MI do you have here?
Anterior.
Anteroceptor.
Septa.
ST
Elevated
segmented
MI.
elevated MI.
Okay. So, Q wave. Is there any Q wave here?
Are there any Q waves here? What do we define as Q wave again? This is why you remember that definition.
So, do we have Q wave here?
This one you have a P wave. There's a small R wave here, Abi.
So, the next
no
one
Q
is
wave.
S.
What about here?
In V1, V2.
In V1, this is a P wave. Is there a first negative reflection there? Hello, is there anything going up after this Q?
After this P wave.
No, so what is this? Q. This is the first negative deflection after the
P wave.
P wave. You can see why I said you write that one before. When it starts getting hot, those things you wrote down are going to save you. In V2, remember I was saying she must be in continuously. In V2, unko? Q wave again. Sometimes, if this patient does not come to hospital in time, let's say they come after 2 weeks, they've drank everything, alagbukum, everything. And they finally say, okay, let them try your hospital. And they hear that you are very good. That you delivered triplets the other day. Then you now did ECG. By then, this S elevation may have come down. But these Q waves will still be there. That will give you the telltale sign. This is why you must remember, you will still need to do the troponin for that patient. And you will still need to intervene for that patient. Otherwise, that patient will die. No be joke. If they don't die then, they will die within 1 year or 2 years. Hello? Hello? Wow, don't answer me now.
So, the pattern you have there is what we call a QS waves. There's no R wave there. So, all you have is just negative deflection. So, you have the first one and you have the second negative. So, the one that should go up
It's not there.
is not there. So, it's a QS wave. So, that's what you have down up to V5 for this patient.
I remember this patient, a 52-year-old, 58-year-old Indian citizen, I think, married to a Nigerian man, and then they came, we had this ECG, we managed conservatively, they refused to do anything in Nigeria, they went to India, and just like we said, all the vessels were blocked. They refused surgery as well. They wanted something divine. Unfortunately, it was not to be. So I remember the name I remember the name. One of my first patients. All right. So you don't joke with it. She died within 2 months or so. You don't joke with it. All right. So T wave. Finally, T wave. The main thing you're looking for in T wave is whether it is negative or positive.
Positive.
Bede? Whether it is negative or positive. Whether it is negative or positive. All right. In this ECG, can somebody read this ECG for me? Give somebody. Thank you. Yes. Go ahead. Go ahead. What's the rate? All of you be trying it. You keep on trying. That's how you know.
It's 100.
100, correct? What's the reading?
It's sinus reading.
Sinus reading. Can you not see you are flowing? Yes? What do you notice next?
The QRS.
Yes? Is the QRS?
It's normal.
Is it really normal? Is it really normal? What about the height of the QRS?
Okay. It's long, it's true.
How long? Is there a left or right ventricular hypertrophy? What do we say for left ventricular hypertrophy? Do you remember?
The left.
Yes.
The V1 needs to be
V1 or
up.
V2. So let's calculate this one. 1,
Okay, no,
2,
V2.
3, 4. Come here again.
V6.
Let's calculate it. 5, 6,
6,
7, and small. So it's 7 and above. So that is what?
Left
ventricular hypertrophy. Aha. Now, ST segment.
Are they all on the vertical line?
ST segments. You remember the ST segment? This is the T wave.
Yes.
This is the ST segment. Are they all on the same line? Look through all the entire ECG. Talk.
If you say no, where are you looking at?
If you say there's ST elevation, tell us. If you say there's ST impression, tell us. Yes?
Where? V6.
Huh?
Okay.
I didn't hear her. What did you say? Talk now, don't be afraid.
ST depression in V6.
In V6.
V6.
Yeah.
Where's the brother of V6?
V5.
V5. There's not much there, but there's ST depression in V6.
Yes.
So, because it's not too clear, what else? Q wave, any Q wave?
Any Q wave? If you say yes, where is the next question? So you have to look at everywhere and make sure there is no positive deflection after your P wave.
This is the real meat. After this one, now you are a star.
V4 and V5, are you sure?
Can you see
After the P wave, there's something going up now.
So it's not the first deflection, Abi? Is it the first deflection?
The first deflection is a positive deflection.
So cancel.
There's no Q
That
wave
failed
there.
this thing.
So there's no Q wave on this ECG. Even if you look here, you can still see something small before the negative deflection.
Yeah.
So there's no Q wave here. So T wave.
T wave. Let her finish now. Where don't run. You never finish. You have not assigned your name. Give her to finish now. You have not assigned her name. You came for ACS 2022.
T wave. Any T wave abnormality?
Eh?
Someone said lead 1. So what happened to the T wave in lead 1?
Remember T wave, we are looking, is it facing up or is it facing down? Normally it should face up except in AVR.
Yes.
So in lead 1, is it facing up or facing down? Facing down. Where is the brother of lead 1? AVL.
AVL.
Is it facing up or facing down? Down. Where is the brother of 1 and AVL?
V5 and V6.
Is it facing up or facing down?
Down.
V6, is it facing up or facing down?
Down.
Oh, no.
So you put there's T wave inversion in
what leads are 1 AVL V5 V6? Check what you wrote down.
Lateral. So there's T wave inversion in lateral leads.
That tells there's something wrong with that muscle. Most times ischemia. Hello? It's not looking simple. We are finished. We are finished. Again, let's remind ourselves. Identify the name, ECG, and rate. I forgot that. The rate, the name, calibration, and the rate. Next, rhythm and P waves. Next, QRS. Next, SC segment and other segments. Next, Q waves. Next, T waves. Shikena for now.
Just making it simple. There may be other things.
There are plenty other things.
This is just simplified step to start. And you can now build on this subsequently.
All right. Now, let's start answering more ECGs. Yes, can anybody try? I think we've done this ECG already. Okay. Can somebody try this? Pick, quickly. Just pick anybody. Thank you, sir. Please go ahead. Go ahead. Give her. Okay, just answer. What's the rate?
75.
75, correct. What's the reading?
The sinus reading.
Sinus reading, correct. You see, you are doing it. What's next? QRS, is it prolonged? The duration, is it prolonged? Is it more than one, is it up to one big box? Is it more than one half of a big box?
It's not normal.
It's normal. Okay, what about the height? Yes?
It's normal.
It's normal. What about in V1? Is it facing up or facing down?
It's facing down.
Facing down, is that normal or not?
Normal.
Normal. Chicken, ST segment? ST segment, look at all of them. Here, is it normal? ST segment?
Normal.
Normal. Anyone that is facing up or down? None. All right. Q wave? Any Q wave? None. Correct. T wave? Anyone facing down? Except this AVR facing down is normal. Anyone facing down in all the T waves?
Normal. Normal.
Check. There is one facing down.
Looking down in V1, but it's
Can you see?
most usually normal.
Most times it's normally facing down in V1. And in children, it's also facing down in V1. So, what is your final diagnosis?
Normal ECG.
Normal ECG. You sign your name. Member, sign, came for ACS 2022. Can you not see? Oh, you can do it. You see, you were afraid before. Let's go to another one. Yes. Good. Thank you, ma. Go ahead. What's the rate, ma? Go ahead. What's the rate?
Let me see. Excuse me, I can't see you.
We will read ECGs today. Tire. When you are dreaming, you just be seeing ECG like this.
60 beats per minute. 60. It's normal.
Based on what?
How did you arrive at 60?
The first 1, 2, 3, 4, 5. The first lead one.
Which first one? Is it this one? 1, 2, 3, 4, or this one? 1, 2, 3, 4, 5, or this one?
No, the lead one.
Okay.
1, 2, 3,
Look
4,
at your
5.
strip here now.
For your rate, it is always better to use the long rhythm strip for your rate, for your rhythm.
1, 2, 3. That's 100.
Is it fairly regular or very regular or
Not
irregular?
regular. It's irregular. It's irregular.
Is irregular?
Yes.
So what you do when it's irregular, just find the average of the boxes that you are seeing. So this first one is about 6 boxes, Abi.
Yes.
This one is 5. This one is 4. This one is 4, maybe 4, 4, 4, 5, 6. So average about 5, Abi.
Yes, that's 60.
300 divided by 5 is what?
60.
60. Uh-huh. Is this sinus reading?
Let me see.
Why is it not sinus reading?
Oh, I didn't say. I'm not answering. Yes.
Okay, is this sinus reading? Whatever you say, I will ask you why.
Okay. Let me see. Sinus reading.
Question number 1. Is the P wave in lead 2 facing upwards? Have you done on the first one?
Yes. Is the RR interval
equal?
Are they equal?
No, they're not equal.
They are not equal, so it's not sinus.
That's number 1.
Number 2, P wave. Is it facing up?
P wave in lead 2, is it up?
Yes, there's a P wave there.
Where?
In AVR, can you identify the P wave in lead 2?
There's a P wave there. Like first.
This is Ali and Angel. Where?
Is it this one?
No, that one, yes.
Yeah.
Or this one?
No, the one right before.
This QRS.
Oh, okay.
QRS. Can you see any P wave? Anybody? No P wave.
But if you check V1, you will see P wave
In
there.
V1, are you seeing P waves?
Yes. Okay.
So you have multiple
P waves. When you have multiple P waves, atrial flutter. But in this case, it's not regular. Okay, so normally atrial flutter may be regular, but in this case, it's not regular. So what's the rhythm here? Say it. I want you to say it.
It's
atrial flutter.
Atrial flutter.
Say it boldly.
Atrial flutter.
So that if you want to collect your money, we'll collect it. Hey, you are not finished. That all? You are not finished ECG now. What next?
That's QRS complex.
QRS complex.
Okay.
Look at it, don't worry, don't be afraid. Is it wide?
Yes, it's wide. Is it?
It starts from, yes, it starts here. It's a little bit wide.
It's wide.
Yes, it's a little bit wide. So, slightly wide, but not too much. Just slightly.
The height?
What of the height?
1, 2, 3. It's abnormal.
What is it? V1, is it facing up?
No.
So there's no right ventricular hypertrophy, Abi?
Yes.
What of left ventricular hypertrophy? Any?
1, 2.
Are you sure?
4.
1, 2,
No, there's
3,
none. I don't think.
1,
It's 5.
4, 5, 6.
It's normal.
Okay. 4, 5, 6, 7. Yeah. If you do V2 plus V5, you will get 7.
Okay. Which is
Okay. So what do you call that?
okay. Left ventricular hypertrophy.
Left ventricular hypertrophy. Yes. What next? ST segment. ST segment. Oh yeah. The patient came with chest pain. They came to you. They heard it just came from ACS, and they don't want to come and pay Dr. Iseko. So they have to come to you.
There's one in V6.
Where?
V6. Elevation.
V6. This is the ST segment here,
It looks almost.
and this is the normal one. It's on the same line.
Almost on the same line.
Okay. Yes.
I think that's the value. V6.
What?
V6.
V2, V3.
V2, V3. Okay.
V2.
There is slight, but if you look at it really, this is the J point. Now, that question he asked about benign early depolarization. Most times, benign early depolarization will happen in V2, V3. And it is convex upwards. So it is going up like this. It is in only V2 and V3. You will not see it V1, V2. These ones, are they brothers? V2 and V3, are they brothers? No.
It's V1,
V1
V2.
and V2, V3, V4. So that's another way you can know that this is benign. Who was asking that question? Yeah, that's another way you can know that this is benign early repolarization. But it's not really benign, but it's there. Okay, so let's leave it. Q wave, any Q wave? Oh yeah now.
Q wave.
No Q wave.
First negative deflection in QRS complex.
Any Q wave? No Q wave. Just say it, don't worry.
Okay.
Don't be afraid of it being wrong. T wave, anyone facing downwards? Any T wave facing upside down?
No.
Talk. Have you checked everywhere? What about this one?
In lead 3.
Is that a T wave? Okay.
This is your QRS. This is your T wave.
Okay.
This is your QRS. This is your T wave.
Okay.
So where else will you
Where
check?
else will you check if lead 3 has T wave?
We check
Lead 2 and AVF.
AVF.
Lead 2 is flat, more or less.
Okay,
And in
AVF
AVF,
is
it's
down.
also down. So you have T wave abnormality in what set of leads?
Inferior leads.
Inferior. You wrote it down before now. Did you write it down?
Yes, I have.
So you wrote it inferior leads.
Okay.
So now let's summarize. What are the main abnormalities you found here now? Number 1.
Atrial flutter.
Atrial flutter is
Number 2.
LVH.
Left ventricular hypertrophy, not so.
Oh, yes.
Number 3.
And then
T wave inversion.
T
in
wave
inferior
abnormalities
leads.
in
Inferior leads.
inferior leads.
3 and ABF. All right, so thank you.
Thank you very much. All right. Are we okay to continue? Let's go to our book. That one is close to you so that you will not say, this is now real. All these ECGs are from cardio care. We have our library has maybe over 20,000 ECGs now. So there's no ECG. I'm not sure there's any ECG in the world we have not seen. So where do we start from? Page 40. Page 40. ECG for all workbook. Page 40. Dr. Ofisoya and Dr. Olaleko is there. Dr. Miriam too. Dr. Inuwa is there. So we have 3 consultants around. If you need to draw them to your book that you need something you don't understand, please do that. So let's answer this one. Use your biro and answer by the side of your book. Everybody try. We are doing our exam now.
Just fill the rate, redeem, and P wave, QRS, ST segment, QT, then your final conclusion.
Yes, camera woman, what do you think? Is this normal? Okay. Correct.
Okay,
See,
the
the camera
heart
woman
rate.
said it's 100 beats per minute. Thank you very much. Yes. You can see ECG is simple, Abi. Uh-huh. What about the rhythm? Anybody? Say again. Normal sinus, Abi, you can see it in front of you there. What about the QRS?
The QRS.
The duration and then the height. Normal. ST segment. It's not easy to teach plenty people like this. It's easier to teach just 10 people. If your organization wants us to come, then here we can come and do it in a smaller room and take maybe a full day on just ECGs. Okay. ST segments. Anybody? Normal, yes. T wave. Q. Any Q? There's a small Q in lead 3. But that Q is not up to 25% of the R wave. Can you see that? Look up, look at Dr. Olaleko. It's not up to 25, so it's not a full Q. Remember, we talk about pathology Q. We put a definition, that's why it's not, we don't count it as anything. All right, T wave, any problems? None. What's this ECG? Normal. Sign your name. You are not sure? Call cardio care. All right, let's go to the next page. Page 41. Yeah, 41. Oh yeah, let's answer. Quick. 100 per minute. Yes. Read him. Jude, find me somebody now. Good, thank you, sir.
Normal.
The reading. Sinus, good. What about the QRS? The duration, is it okay?
It's okay, sir.
The height, is it okay?
Yes.
Yes. Are you sure? If you add V1, 1, 2, 3, plus V5, 1, 2, 3, 4 and a half. Add your V1 and your V5. How many big boxes? Okay. It's up to 7.5.
Yes, sir.
So that is what? Left ventricular hypertrophy. Sir, can you see it?
Yes, sir.
Good. So you add the V1, the one facing down, and the V5 facing up. Add those two. So you are doing the highest between V1, V2, and V5, V6. You add it up.
It's more than 7.
It's more than 7. Good.
It is left ventricular hypertrophy.
Left ventricular hypertrophy. So write it down there. You know you are signing this ECG to go out from your hospital.
Yes, sir. Yes, sir.
ST segment. You never run. The patient came with chest pain now. ST segment. Any elevation or depression?
Let me see. This elevation.
Where?
V3.
Not really.
Not really. Okay. The elevation in the precordial list typically should be more than 2 small boxes. Okay. 2 very small boxes, but this is not up to even 1 small box. And then if it's in V3, you should also check V4. It's not there on V4.
It's not.
So it's only Wiki. He's on his own.
Yes, sir.
I bet Wiki na joke. Yes.
Thank you, sir.
So what is the submission?
Q wave.
Q wave.
Don't run. Q wave. You have to finish it.
Q is normal.
Wike's man is here. Dr. Dafe. Dr. Dafe is here from Port Harcourt.
It looks normal, the Q.
Q, no Q wave, okay. T wave, any T wave abnormality? Any T wave abnormality? Look, and write it down.
Any T wave abnormality?
Look at all the leads. TCG is so simple, isn't it?
I see it's elevated in V3.
We're looking at the T wave now.
T wave. Is it facing up or facing down? T wave, all the T waves look fine, oh.
They look fine.
A little bit, okay, it's a little bit upside down in V1, Abi, and V2, slightly. So maybe septal leads, anterior leads. Fine, great.
So LVH in this patient, that would be a major submission, left ventricular hypertrophy.
All right. Let's move to the next one. Number 42. This is how you know ECG. You just keep on trying. Give us Nena. See her in front here in purple. Yes, with glasses. We're in extra time now.
1, 2, 3. Rate is 100.
Rate is what?
Rate is 100.
100, fine. Rhythm?
There is P wave.
Rhythm, what's the rhythm? We don't pass that level. We have entered the stage 2. Is the rhythm normal or not?
It's normal.
Normal sinus rhythm. Thank you.
QRS.
QRS.
Okay. QRS is normal.
It's normal. It's not too wide. It's not too high on any of them. Is the QRS really normal? Are you sure it's normal? Look at the limb leads. Look at the limb leads of the QRS. Are they up to one big box? Are they up to one big box?
No.
So you have what do we call that one? Low voltages. So there are low voltages where? In the limb leads. This is a sign of an abnormality. It means the heart muscle is not getting enough current. NEPA. Right? Remember, I wrote it down before.
Yes.
If it's less than a big box, the QRS, all of them, they're less than a big box, then we say they are low limb voltages. So that QRS has a problem. So write that down there. ST segments.
ST segments. Some. Wait to.
ST segment, any major changes?
No.
Okay. We've jumped the Q wave.
Q wave. We've not done Q wave.
Q wave.
Yes.
Q waves. Okay, somebody is saying something.
This is a senatorial candidate that collapsed at a rally.
Q wave.
So Q waves.
The press are outside asking you what's happening.
Look at all the leads, the whole 12.
I'm coming.
Look at the chest leads.
This number.
Any Q wave, okay. Q wave is first negative deflection. Any negative deflection after a P wave?
Yes.
Where?
V1
and
V2. Where again?
V3.
AVR, yes. Although it's normally upside
It's
down.
normally upside down in AVR.
So V1, V2,
V2, V3.
T wave. T wave. Look at the same areas where you have problem already. That are telling you that there's problem. Are they T wave inverted there?
Yes.
Yes. So what are you talking about here now? What's happening? Up to V4 self. V1 to V4. So what's the problem here?
So V1, V2, where is it looking at?
V1,
V1, V2, what you wrote down? What did you write down? V1, V2 looking at where? Septal. V3, V4 is looking at where? Anterior. So we can see Q waves here. If this person is coming with chest pain, this person likely has an MI or has had an MI before in this area. Okay, so he either has had an MI or still shouting, vote for me, or he's had an MI. You should do your troponins and you should send them to the cath lab ASAP. Okay, so you made the diagnosis now. What else is there? Isn't the ECG simple, sir? Yes? It's not simple. Show me the one that is not simple. Just show me. Just prove me wrong. Choose any of these ECGs that you think is not simple. Page 45. Let's do page 45. Page 45. Dr. Awo, nobody's asking any question, Abi. They are all getting it. They are either all getting it or they are all not getting it. Page 45.
So what's the rate? The rate is 100.
Rate is 100?
Yes.
Read him. Just sharp, move.
It's sinus.
Sinus.
Yes, sinus. And then
So the QRS.
QRS.
The voltages, are they normal?
The QRS duration, is it normal?
No.
Really?
The duration, look at it very well.
QRS.
The
This
duration.
box from here to here, Abi?
It's normal.
It's normal,
Yes.
not so?
Yes.
Good.
The height.
The height far.
In the limb leads, are they normal?
No.
So it's a little bit more than
It's only one that is up to 5.
short. This one is
Others are short.
Others are short, but it's up to 5. At least one is up to 5, so it might say lowish. Any other thing? ST segment?
Elevated.
Where?
Oh my God.
Where is the ST segment elevation?
V1 to V6.
Awesome. This is what we call tombstone appearance. Tombstone. This is because to likely take the patient to the grave, but also you need to intervene ASAP. These are real life patients, though. These are not cases from somewhere.
Is a 40-year-old hypertensive diabetic.
Oh.
Referred from FMC Jabi.
Okay.
Is 2 years, 6 months post PCI.
Oh.
Doing well.
Doing very well.
Usually.
Straight we put the stent in and the patient is fine. Thing came back down. Everything.
Usually comes in with malt and plantain chips to the clinic for everybody.
The guy is checking our own cholesterol, whether we too can get his. All right. So you saw that, Abi?
Yes.
Good. What else? Q wave.
Q waves.
Q wave. Is there any Q wave there? So when
Yes.
you're looking for a Q wave, look at the P wave. Then look before the next deflection. Is the first deflection a negative one?
Yes.
Okay, so that's a Q wave, Abi?
Yes.
Where else are you seeing that kind of thing?
V2.
V2 is there, V3 is
V3
there,
is there,
V4 is there, V5 is there.
five,
These are
6.
very extensive MI.
So anterior septal lateral. So extensive MI. T wave.
T wave. Inverted where? Talk now, talk. Don't worry.
V4, V5.
V4, V5, V6. What of this place, Uncle?
It's inverted from V1.
Okay. V1.
It's inverted too, Abi?
Oh, V1
all
to V6.
the same areas too.
Also look at lead 1.
Lead 1 too is inverted. AVL 2 is inverted.
Inverted.
Very extensive MI. So put your sinus name. What's the diagnosis?
Extensive MI.
Extensive MI where?
Everywhere.
That's everywhere. You came for ACS.
Septal and
Anterior, septal,
and
lateral. Call Dr. Iseko immediately. Call cardiologist immediately. Let's put a stent. Quickly to save this man's life. Okay? It's not easy. Let's do. This man works in telecoms. Page 44. Look at my old ECGs. Page 44. But also, you know this guy. He's on anticoagulation now. Yes? Yes, give that man. Good. No, the one with cap. Yes, sir. Awesome. You look like the governor of Borno State.
1, 2, 3, 4, 5. The rate is 60.
60, good.
Then
Page 44. Is it 60? 1, 2, 3,
It's 4.
it's 40.
This is 4.
Page 44.
Okay.
Is it 44? Yeah, it's 44 now. Page 44.
We have 4 boxes there.
It's clearer in your notebook.
1, 2, 3, 4. That's 75.
75, good.
75, yeah.
Reading.
Normal sinus.
Normal sinus, awesome. QRS.
QRS.
Normal. No, if you don't understand anything in your book, just raise your hand. Because doctors are around, they will just come to you and help you. Dr. Officer,
The QRS is normal.
QRS is normal?
Yes.
Are you sure?
Yes, sir.
Are you sure? Are you really sure? Look again.
Yes.
V1, what do we say about V1? V1 should be facing up or down?
We said the R wave in V1. In V1, once the R wave is looking up,
What
that
is
is
wrong?
not normal.
Right ventricular hypertrophy. This is a young man, they sent him to my office and say hypertension or something. Once I just saw the CG, I said, there's something wrong there. The guy, he was hiding his history. When I told him, I felt like a prophet. Yes, what's there? Say, sir. V1 facing up. What did we say? Just check your book. You wrote it down.
Right ventricular hypertrophy.
Beautiful. Right ventricular hypertrophy is there. Okay? Any other thing? ST segment.
ST segment.
Is there anywhere where the S segment is up or down?
Where?
Where?
V2.
V2, yes. When you make it, you see one, look for the brothers immediately.
V3.
V3. What of this one, this brother? V1. What of this brother?
V4, yes.
Is lower now. V4. What of this one here? It's a little bit down. This one is normal. What of the T wave?
The T wave.
You will see that those things normally follow together because they are all signs of ischemia.
Q wave.
T wave, is it up or facing up or down? Any T wave that is facing upside down?
Yes.
Yes? V1, Abi, is facing upside down, it's not facing up. What of the other ones? Here?
V2.
V2, where? Here? Where? Here? Good. So summarize what you have found so far in this ECG. The main abnormalities.
Left ventricular hypertrophy.
Left, not left.
Right.
Right.
Right ventricular hypertrophy.
ST segment, depression or elevation.
ST segment what?
Depression.
Depression where? V1 to V6. Abi?
Yes.
That is anterior, septal, and
lateral.
T-wave inversion in the same areas, not so?
Yes.
You sign your name. Call the cardiologist. I made the diagnosis. Who taught you this? You came to ACS 2022. All right. I think we can stop here. Let's clap for ourselves. Please take a few minutes and go through some of the other ECGs so that we can help you through it. Take a few minutes and go through the ECGs by yourself. Go through it with the people on your table. Go through it with the people on your table. We will break for lunch and for those going to the mosque. And then we'll reconvene by 2:10 sharp. ACLS, if you miss the first slide, you have missed. I think 2:10 should be, mosque will be over by 2:10 now. 2:10 sharp, we start here. Lunch. Bring that food. That yesterday's food was very sweet. Those online, we will send your own. Just click food on the Zoom platform. If you have any questions, just raise your hand. Keep on trying. Raise your hand and somebody will come to you. Please try. Only 5% of you will try after this. Those are the people that will come next year and be my good disciples. The remaining of you will go away today and will never check this again. I'm not swearing. It's just life. I've been doing this for a long time, at least close to 10 years now. 10% of you will go back, check it. Some of you will go the extra mile and go to your ECG department and pack all the ECGs and start reporting them and send them on the group. So I have a problem here. Those ones will never forget ECG for the rest of their lives. But the others, in 2 years' time, they will not know what the difference between P-wave and QRS again. Try with the people on your table as the food is coming. Try with the people on your table. We are going to ACLS and we are going to use this thing very well. If you don't understand this, you cannot resuscitate a patient. Yes, yes.
No, I
You
want
sign on.
some clarity with the last one that we did.
Eh?
The last ECG that we did.
This one? Which page?
44.
Okay, that's this one now.
Yes, right ventricular hypertrophy, depressed ST segments, depression, V1 to V6. So, with the right ventricular hypertrophy and the ischemia in the anteroceptal leads, so what are we thinking?
So in this case, when we see ST changes with the right ventricular hypertrophy in V1 and accompanying ST segment changes, what typically happens is that those changes are due to the strain on the right ventricle. The right ventricle has become hypertrophied and it's now become so hypertrophied and strained that it's not getting enough blood supply. So it's not able to relax well before it contracts again. So most times when you see this kind of one, patient has a pulmonary embolism. You see a patient like this, think of a pulmonary embolism.
Okay.
Think of COPD, something that caused the right ventricle to be under so much pressure. Think of congenital heart disease.
All right, thank you.
Thank you very much. That's the clinical implication of that. Please, question here.
Please, sir, in the bundle branch blocks, can you go through the Maro and the William again?
Okay. We look at the V1 and we are looking for a first positive deflection and then it comes down before it goes up again. What we call an RSR pattern. RSR pattern. Pamela, I expect movement to be happening. RSR, that looks like an M. When you see an M in V1 and the QRS is prolonged, so the first thing is that you see a QRS that is prolonged, telling us that there's a block. It's taking a long time for the impulse to go around the ventricle. Once you see that, that's the first sign that there's likely a block. The next sign, now you look at V1, and you can see that there is RSR, Maro. That is right bundle branch, MRW, Maro. And then in the left bundle branch block, you have the M is in V6. WLM, William. That's how we look at it. So now let's look at the real ECG. And we say the left bundle branch block is the one you should keep your eye out for. Because if somebody has a chest pain or you see a left bundle branch block in them, chances are they are having an MI. So an MI can come with ST elevation or it can come with a left bundle branch block. So look at this case. Is the QRS prolonged? See where the QRS started from here? And it's here. It's prolonged, sir, isn't it? So now let's look at V1. This V1, what does it look like? Does it have the any pattern? M. RSR. And then in V6, you can see these ones. It's like a W. So what kind of block is this? Right, marrow, exactly. If it is left bundle branch block, this thing you are seeing in V6 will be here. And this one you are seeing in V1 will be here. That's just the difference. And that's a left bundle branch block. Hope that helps, sir.
A question, yes, sir.
Yes. Thank you very much for an exciting lecture. Please, what are the SE changes in pericarditis?
Okay. In pericarditis, what we are looking at is the shape of that ST segment elevation. Like Dr. Iseko showed during his presentation of chest pain yesterday. And the one we showed, like the ECG in page 45, you will see that it is convex up. But in pericarditis, it is a saddle-shaped ST segment elevation, like something you can sit on. And in pericarditis, it's going to be almost diffuse, as in affecting all the leads. Because in pericarditis, it's affecting the pericardium. So it's not limited to a specific blood supply area, like you have in patients with heart attack, where you have either maybe inferior, anterior. The changes will be generalized, almost going from V1 to V6. Then you can have that PR change, like you talked about, the PR segment, where we're looking at that AV node at the beginning, can be a little bit depressed. So that's how, so the shape is either like a spoon or saddle, while in MI is the other way around. Thank you.